So your adolescent patient is sitting in front of you in the office, most likely with her mother, occasionally with her father. You've done all those tests done in a reliable laboratory. Metropolis has given you all those labs. You've taken a good history, you've done a clinical examination, and now it's time to make that final clinical assessment. You have to make a diagnosis. Is this PCOS? Are you going to label this child as PCOS? What is going to be your line of counseling? What is therefore going to be your line of management? And very often, this is what the problem happens at that time. Because you've got all these labs, you've got all that information in front of you, but collating all that information, the history, the physical examination, the lab sometimes can indeed be a challenge. So case in point, for example, we have this girl, 15-year-old, she's got her periods maybe at age 11. Menstrual cycles are now coming every 2 to 4 months. And as usual, they've come to you with this ultrasound showing polycystic ovaries. Who says this is PCOS? Is this PCOS? Who says yes? Who says no? Okay, so like you see, there's a division in the audience. I'm giving you a second case right now, a 19-year-old girl. She started her periods maybe at age 11. Her menstrual cycles have been coming every 3 to 4 months. She's obviously hirsute. Ultrasound shows no polycystic ovaries. Well, who says this is PCOS? And who says this is not PCOS? So this is always where the problem lies. And why does that happen? And that's because the clinical correlation with the lab markers is always not that easy. What happens? You have this case, biochemically, androgens are high. Clinically, everything seems normal. Similarly, if you do a lab, you have on ultrasound, you have that polycystic ovarian morphology, but menstrual cycles completely regular. And then again, you have high insulin levels if you've tested them, but the patient shows no clinical features of insulin resistance. Where does one put this all together? How does one come to a conclusion? Now, the criteria for diagnosis of PCOS in the past has really been, again, very confusing because, again, you have various permutations and combinations of the various findings, a polycystic ovarian morphology, hyperandrogenemia, you have the anovulation, all of that put together in various permutations, combinations would say 2 out of 3 criteria, 3 out of 3 criteria makes the diagnosis for you. However, none of the criteria so far ever addressed the insulin resistance and its corresponding metabolic manifestations. And of course, the criteria again have this very important caveat that you have to exclude the other etiologies of androgen excess and menstrual irregularity before making a final diagnosis.